prepared. Okay, so let me try to increase my increase my volume here. Okay. Hopefully you'll be able to see this, all right? So I want you to understand the common complications of acute pancreatitis. Oh, great. My Google's talking to me. Okay, so in particular, if you see some of the stuff that have in parentheses, like for instance, I really want you to understand that internal bleeding is something that's really important with acute pancreatitis, as like if you were to have if it becomes so inflamed to the point where it can actually cause bleeding, it's like something that's really, really detrimental. Okay. Ways to control development of ascites in your patients with cirrhosis of the liver. In particular, you want to think about one of the ways we want to control is you want to have a diet low in sodium, right? And the reason, the caveat behind the diet low in sodium is because why? Remember, water follows salt, right? So if you have increased amounts of sodium, you're thusly going to have increased amounts of fluid. So therefore, you're going to wind up, the ascites is going to get huge. So they usually tend to have lower sodium restrictions, right? And then also the fluid restrictions on top of it. What types of hepatitis often lead to cirrhosis of the liver? Well, the biggest one is hepatitis C, is what often leads to cirrhosis. What assessment findings are common in patients with late stage or advanced cirrhosis? So advanced or late stage, you're going to have jaundice, clay-colored stools, or icterus, right? And just if you see icterus means yellowing of the skin, the sclera, mucous membranes. Then you also are at risk for ascites, petechiae, which is small red or purple spots that appear on the skin or mucous membranes. And their urine tends to be more concentrated, so it'll be very dark in color. So what are some common serum lab levels in patients, right? So you have to remember, in certain circumstances, if you look at a BUN, if you're just as an example, if you're looking at your BUN as a source of whether or not a person's hydrated, the BUN and creatinine serum could be different than the BUN and creatinine in a urine, right? So pay attention sometimes when they actually specifically ask you serum, right? So they want blood level. So what are common serum lab levels for patients with cirrhosis? And they tend to have elevated INRs, elevated serum ammonia levels, and elevated PT, right? Prothrombin time, right? So INR and PT go together, right? Along with PTT, but typically it's elevated PT and elevated INR, okay? So why do they have the elevated serum ammonia? Why? In cirrhosis. That liver's not functioning right, right? It's scarred. Cirrhosis means scarring, right? So it's not filtering correctly. So therefore, ammonia is a byproduct of protein breakdown, right? And ammonia levels are going to be elevated. So how do we get ammonia out of your body?
Lactulose.
Right, exactly. Because it's going to make you cuckoo, right? Toxic environment in your brain. All right. Hepatitis C, how's it spread? Spread via blood to blood transmission, associated with illicit IV drug needle sharing, blood and organ transplants. This is important. So if you get blood that wasn't screened right, you could get hepatitis C from it. An organ transplant. This is why they ask you whether or not a person's history, if you're an organ donor and you suddenly die and you want to transplant your organ, did they have hepatitis in the past, right? Accidental needle sticks, unsanitary tattoo equipment, sharing of intranasal drug paraphernalia. And I forgot to put it in here, but also sexual contact, right? Can be as well. What are some routes of transmission for hepatitis, especially hepatitis A? In particular, ingestion of contaminated water, shellfish. So some places, as an example, where this kind of occurs is like on cruise ships. Cruise ships that contaminate the water, and it's like you wind up with like Legionella or different types of contaminated water can actually wind up also leading to hepatitis A. What if it's like the recycled water wasn't filtered enough, and they cooked a whole bunch of shellfish and dumped it into the water, and it got filtered in, and somehow you're now ingesting it, right? So hepatitis A can be done that way as well. Okay. Hepatic encephalopathy. Okay, what is that? What is hepatic encephalopathy? It's just your liver is so bad that it's causing you to go a little cuckoo, right? You're gonna have inflammation in your brain. The signs and symptoms include this thing called Fetter hepaticus. As an example, this is one of the things. Besides you being confused, right? And we have to give you lactulose because the ammonia is built up. But some of the other things that you have, your breath will smell like poo, right? But it's also very sweet. It will like a sweet smell, but also smell like poop as well, right? It's called Fetter hepaticus. So we mentioned before about the treatment of that HE, which is lactulose, right? So it's important, lactulose, and why it's being used, okay? So it's like a chelation therapy, ultimately. It's a medication that is going to help pull out that ammonia, right? It pulls it into the gut, and then it's evacuated through the gut. It makes it go poo. It's going to give you diarrhea. So what are some of the expected outcomes and side effects, right? So expected outcomes is you're going to start the patient's going to start thinking more clearly, be more oriented because of that lactulose. And in some of the side effects I just talked about just a moment ago, it's like it's going to be maybe horrendous diarrhea, might be explosive diarrhea. It's probably the most common. Some of your signs and symptoms of the liver transplant rejection. So any kind of rejection from any kind of transplant, pretty much going to like they're going to. Some of the most common signs and symptoms are going to have that fever, right? But in particular for that liver transplant, is you might have right abdominal quadrant pain, whether upper or lower, doesn't matter, but right sided, and obviously you become more jaundiced. For pancreatic enzymes, so the pancreas is partially removed, or you have chronic pancreatitis. So you're going to need enzyme replacement therapy. Just like if you were to have a problem with your thyroid, as an example, you're going to have to take supplements, right? So in pancreatic enzyme replacement, you have to take immediately before. You have to take them before eating any meal or snack. right?
I learned that.
And then part of our teaching, we have to make sure that the client would make sure that they clean their skin with the food, with the enzymes that they're using to eat, right? And specifically, give good oral care, specifically their lips, because after drinking that preparation, the enzyme preparation, it could cause damage to the skin. So it's very important. Okay, some signs and symptoms of pancreatitis. Ascites, biliary is ascites occurs because of biliary obstruction. Steatorrhea. Steatorrhea is known as fatty stools due to lack of lipase. That's why, because it's not free. It's not the pancreas is not able to produce lipase, so therefore your stool becomes very fatty and may also be yellow and jaundice color, right? Um, Jaundice in general, it usually occurs because of biliary obstruction, polydipsia, because have to think about it, right? The pancreas, diabetes, right? So the pancreas is jacked up, you're going to be diabetic. So you might have polydipsia as well as polyuria, right? You might be very thirsty and then also urinate a lot. Thusly, they're going to wind up having weight loss because of that reason, right? Think about like diabetic ketoacidosis, DKA. They're just going to be peeing it out, peeing it out, peeing it out, peeing it out. Everything they're going in. Okay. So they're obviously also going to have extreme abdominal pain, nausea, vomiting, possible fever. Possible fever is always good. Anything with itis, right? Itis is inflammation, ITIS, and that usually means you're going to be fever, right? So, what are some common serum lab values in acute pancreatitis? Well, some of them include elevated amylase, elevated lipase, right? This is an acute, important, acute pancreatitis, not chronic, acute. You're going to have elevated amylase, elevated lipase, elevated glucose, decreased calcium, decreased magnesium, elevated bilirubin, and elevated leukocytes. So it's active infection, so therefore leukocytes are white blood cells, right? They're of course are going to be elevated because it's an active infection, right? You wouldn't see decreased. Okay. Right. So in chronic pancreatitis, though, with blood work, you typically don't see elevations in amylase. They're just kind of slightly, maybe slightly elevated, but usually it's just the lipase that remains elevated. So how to prevent some acute exacerbations of pancreatitis? So what's your teaching going to be? Well, your teaching is going to include stuff like, hey, you shouldn't be drinking alcohol. You're going to need to increase your rest, like sleep well or resting well, decrease activity. You need to relax a little bit because it's going to affect you. You want to avoid caffeine, and you're going to encourage small, frequent meals, and then that are basically going to be high calorie as well. High calorie, small, frequent, high calorie. All right, the gallbladder. Let's talk about that. Some signs and symptoms of cholecystitis. So remember, cholecystitis means inflammation of the gallbladder. Cholelithiasis means there's stones, gallbladder stones, right? Lithiasis. Cystitis means it's inflamed. So in chronic situations of gallbladder disease, you're going to have jaundice, clay-colored stools, and dark urine. And in acute / also chronic stage, you may see fever, a positive Murphy sign, right? increased discomfort of inspiratory rest or catching of the breath during deep inspiration, upper abdominal pain after eating. Specifically with that Murphy sign, it's just like, if you were to have a patient lay supine, put your hands down on them, take a deep breath and push and then let go. And as they're breathing, when they breathe in or breathe out, they're going to have more pain, right? As you're assessing that site, right? So check out the Murphy sign. And the last question there, how does a nurse care for a patient with an external percutaneous transhepatic biliary catheter? Fancy words. So there's so much inflammation. Like someone say that if you're going to need to do the ascites is huge, and we need to drain that ascites, right? Well, it's called external percutaneous transhepatic biliary catheter, right? A biliary obstruction. So regardless, just like if it were a Foley catheter, same deal. You want to make sure that the position that drainage bag is going to be lower than the catheter insertion site, right? So if they're walking, then it's obviously going to be like down at hip level. If they're laying in the bed, then it's going to be below the surface of the bed, right? So you want to always make sure that it's draining. That's the bottom line. Okay. So there's also going to be some endocrine on this exam. So what I want you to do is remember some stuff here. Aldosterone. Aldosterone is a hormone secreted by the adrenal cortex and causes water and sodium absorption to maintain that body fluid volume. Renin is secreted by the kidney to trigger angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2, and thusly helps control that blood pressure by osmotic pressure. And lastly, that magnesium and sodium are electrolytes and they're not hormones. Sometimes people get them confused. Okay. Aldosterone increases reabsorption of sodium and excretion of potassium. So therefore, in hyperaldosteronism, it causes hypernatremia, hypokalemia, and metabolic alkalosis, right? So that sodium level is really, really high, and thus you're going to retain some water. It's going to cause you to have hypokalemia. So because of that water volume being so increased, it's going to be more solute, right? So therefore, it's going to be more of an alkalitic environment versus it being an acidotic. So hyponatremia, hyperkalemia, and acidosis are manifestations of adrenal insufficiency.
Hey, TJ, can you scroll up for just a second?
Mm-hmm.
Awesome, thank you.
Yep, no worries. So again, that aldosterone increases that reabsorption of sodium and excretion of potassium. So if it's in a hyper state, too much aldosterone, it's going to cause hypernatremia. Like, because it wants to reabsorb sodium to begin with, but now it's doing it like crazily, and therefore it's going to create a hypokalemic event as well. So that leads to metabolic alkalosis, right? Metabolic, think about because of the fact that it's endocrine, so it's kind of metabolic in nature. And water follows sodium. So think about that. And so therefore, the more water there is, the less acidic it is. So it's going to be alkalitic. So that hyponatremia on the opposite, hyponatremia, so in say hypoaldosteronism, you're going to have hyponatremia, hyperkalemia, and acidosis from that adrenal insufficiency. So the aldosterone, there's not enough of it being produced. Okay. In hyperparathyroid, too much going on in the parathyroid, causes increased reabsorption of calcium from the bones. So it increases the chances for you to have pathologic fractures. So that's why if somebody has out of control hyperthyroidism, strike that hyperparathyroidism, there increased risks of having fractures, right? And even simply by moving them in the bed, like we could break their leg. So that's why we have to make sure we use like a sheet and carefully boost them and move them up. Okay. And then lastly is serum inappropriate antidiuretic hormone, or SIADH. They tend to have, clients often have delusional hyponatremia. So the lower levels of sodium occurring because they're too diluted. And the client needs a fluid restriction. So remember with SAADH is kind of like diabetic ketoacidosis, similar. It's like very thirsty, they're going to drink, and they're going to pee. Everything that they take in, they're going to pee out. So in order for us to fix it, by adding sodium to the client's diet, it's not going to do anything. So it's not going to answer. The answer is a fluid restriction. And so therefore, if we stop bringing the fluid, it will eventually correct itself, the sodium, and will affect with the sodium to potassium shift, and things will work out. So usually that happens is that fluid restriction could be as low as 500 to 600 milliliters in a total of a 24-hour period. So it's like it's incredible fluid restriction. Okay. So the caveat again is adding sodium to the client's diet was not going to do anything. It's not going to do anything. So the answer is a fluid restriction. Okay. All right. So that, my friends, oops. Ah, there we go. And okay.
Can I see the first page, please, Professor?
Mm-hmm.